Okay, good evening, everyone. Welcome to Washington. Welcome to the AUA. Thanks for joining us tonight. Thrilled to have you all here. Our presentation tonight is Maximizing Non-Muscle Invasive Bladder Cancer Outcomes. I really like the title of Personalized Risk-Adapted Approaches with Intravesical Therapy and Collaborative Care. It really brings in a couple of really important concepts. One, personalizing care, tailoring, precision. We're using these words very often now because it's important to think about what's suitable for certain patients. You know, their clinical characteristics, their of the disease, and also their preferences, their risk aversion, risk seeking, and then collaboration. There's all these really interesting concepts to collaboration. Working with your uro-oncology specialist if you're a generalist and super busy with many things. Almost all urologists now take care of folks with micro and macro hematuria. They discover bladder cancer lesions. And how do you think about this? Because the world of bladder cancer and NMIBC, certainly in MIBC and metastatic urothelial or MUC, has just exploded. And we're just going to focus on intravesical NMIBC tonight because we only have an hour. But this is such a rich area. I'm really glad you're all here because when Bogdana Schmidt, my incredibly talented colleague and co-chair for this program, is going to run through all of the approvals and all the things that are in pipeline development, which are super, super exciting. And they're exciting because, you know, it's a way to optimize patient care. I like the word optimization as opposed to intensify or de-intensify. We're always thinking, how are we going to optimize patient care? So thank you all for coming. This is a CME program, and it's done in conjunction with the American Urologic Association. Again, welcome to the AUA 2026. It's myself and Dr. Bogdana Schmidt. She's assistant professor of uro-oncology at the Huntsman Institute in Salt Lake City, Utah. And I'll just tell you, other than the fact that you want to go and visit her because she runs an incredible program, but the skiing there is, I think, the best in the world. Who here is a skier? Raise your hand. Okay, we're going to have to, we need more skiers. We're going to cancel the program, sorry. All right, so thanks for coming tonight. We have in-room, you all are the in-room learners. We have virtual learners on. And for the virtual learners, you can get onto your and type in your questions as well. I really want to thank the folks from PeerView for helping us put this together, and very importantly, the folks from Fairing for sponsoring this. But this is totally CME, so obviously fair and balanced and hands-off, but they helped support this. Just by way of disclosure, I've done a lot of work with the Fairing folks. I know Dr. Schmidt has as well. And we're really appreciative to their contribution to GU oncology, both on bladder cancer and in prostate cancer. So you probably saw this up here a little while ago. If you download the QR code NMIBC 26DC, easy to remember. A bunch of you, if you download this, and you'll see many of you will already win gift cards right now. So congratulations to you. This could lead to early retirement for many of you. It's a big prize. And then we're going to have more of these prizes. Some of you are winning them right now, but you'll win more at the end. It's a bribe, okay? They were bribing you because we want you to complete the pre-event survey, answer polling questions, and submit questions. If you do all three of those things, it'll increase your likelihood of winning prizes at the end, in addition to having a really nice meal, and hopefully get some good education for myself and Dr. Schmidt. So if you see this green thing on the, that tells you you've won, that means you've won. A really great educational tip from me. So anyway, so thank you all for being here. You don't have to take any photographs. All the slides can be downloaded. Everything that we're going to be showing you, as well as practice aids, it can all be accessed with this QR code. And if you need any more information regarding this, you can email to live@peerview.com. They have an amazing library of other presentations all throughout different concepts and topics in geo-oncology. So I really encourage you to do that. So just kind of get started on these ARS things. Answer this question on your phone or your laptop, whatever you're using. There's no right or wrong, and you can pick as many as you want. Which of the following represents a challenge to your treatment decision-making for patients with NMIBC at your practice or an institution? Adequately defining BCG unresponsiveness. And by the way, fill it out and answer, like it's not just you, but all of your colleagues. Access to BCG, understanding available and emerging bladder-sparing options. Most patients clearly are not looking to have their bladders removed. Providing patient counseling and education for available therapies, managing scheduling, preparation, and coordination of therapies, that throughput that's really important whether you're in academia or community, and awareness of clinical trial opportunities. So let's see how we do with that one. I was told we were going to have music, but oh, there it comes. By the way, if you know the name of the song and you shout out the right answer, that increases your chance of winning prizes. All right, so which of the following represents, these are all issues. I mean, Bogdana, what do you think about this? I mean, it's almost an even split, quite frankly.
Yeah, I think it definitely shows that there's no shortage of challenges in this patient population.
Yeah, 100%. And so hopefully this educational program will solve a few of these, or at least help you understand those issues better. Okay. I think we got all our responses. It's great. There we go. Okay, so what are our objectives today? We talk always about level 1 evidence and how that becomes within our guidelines. We'll show you some different information on the different guidelines. Curious to which ones you prefer or don't. Clinical evidence, what is that evidence and what ultimately makes it important for you in terms of modern, today, contemporaneous intravesical treatments for NMIBC. We'll talk about intermediate risk. We'll talk about high risk particularly as well, maybe touch on low risk. Appropriate incorporation of these therapies. How do you balance that between patient preferences and your therapeutic goals? What's important to you in terms of recurrence, in terms of progression? And how do you have that conversation with the patient and get to shared decision making? Collaboration. So many great treatments out there, but how do we effectively implement these treatments and work with tolerability, safety, adverse event, and risk management, as well as educating patients and their caregivers? So this is a nice long list of the challenges in NMIBC treatment. It's not a one-size-fits-all. There is heterogeneity with unique considerations related to every class of therapeutics. Dr. Schmidt is going to go into more data on where that heterogeneity fits into the clinical trial landscape. But we're going to spend a lot of time on high-risk NMIBC, and what we fear is, of course, the risk of progression. High-risk NMIBC, most data would suggest it's about 25% of that NMIBC newly diagnosed population, and there are high failure rates, and the things that we worry most about is progression, but certainly recurrence, whereas in low risk and intermediate risk, it's really more of a recurrence issue, a little bit of progression on the intermediate risk, but certainly those patients who fail treatment, fail induction and maintenance, adequate course of BCG, what's available to them to help them avoid going to cystectomy, different accessibilities in different parts of the world, typically more US versus non-US, but we'll address that as well. The importance of post-TURBT installation of therapy. But we know that when we look at guideline recommendations, whether it's IBCG with Beacon, IBCG with SITC, AUA and SUO, ASTRO, or NCCN, we see that there's just a lot of patients are not getting the guideline recommendations. The U.S. is unique. I think most countries outside of the U.S. have not been as bothered by the BCG shortage. We only have one manufacturer. That may change in the ensuing years, but it becomes an issue that many U.S. urologists and medical oncologists have to deal with when we don't have the standard of care BCG accessible, which has been a standard of care now for nearly 50 years. Ultimately, there's been a lot of data that clearly supports that patients want to avoid or certainly delay cystectomy. If you're going to delay cystectomy, can you do it safely? Safely meaning, can we get to the discussion of cystectomy and not miss a window where patients develop metastatic disease? And so ultimately, what are some of the new therapies that are out there? And again, Dr. Schmidt is really going to go into those in a lot of nice detail. And I don't think it's overwhelming. I think it's going to be very inspiring to see what are the current approved therapies in the U.S. for BCG unresponsive disease and the several really important therapies that are coming forward as well. And again, we're going to focus on intravesical tonight, not on systemic therapies. You all have seen this particular slide, I'm sure, many, many times. I would draw your attention to the stratification of low risk, which really has more and more data suggests that these are patients that can be just very comfortably be watched with possibly just annual cystoscopies. That's a really important area of advancement so that we reduce burden to patients and burden to the economics of the healthcare system. But what's particularly exciting is the high-risk group and the intermediate risk group. And so you see the high-risk definitions here. You can read through them for purposes of time. It's classically the TAG3, the T1, the CIS, but then you see some of these other additional risk factors which can make you go from high risk to very high risk. I think that's very important. And more we'll see subgroup analyses looking at that, both in intravesical and also in systemic therapies. And then the intermediate risk is really everything that sort of nicely falls in between the high risk and the low risk. So what are the things that concern you the most? The things that concern you and keep you up at night after you've seen some of these patients, particularly the patients with high risk, is progression. We want to not miss that window and say, oh, did I miss the, quote, historical gold standard of radical cystectomy? And these are some of these features, and we'll talk more about that, that are concerning for progression. 15 to 20% of these patients assuredly can result in that. A much higher rate of recurrence, but then also the very high rate of recurrence in the intermediate risk. And there's a lot of heterogeneity to the intermediate risk group. Again, I already talked about the low risk of recurrence and almost non-existent risk of progression in the low risk patients. Now, I draw your attention to this. This is kind of really interesting because this is the 2016 overview of the AUA SUO guidelines for non-muscle invasive bladder cancer, and nicely trifurcated at the very bottom of low risk and intermediate risk and high risk. And you can also look through the importance of the TURBT, which is not to be underestimated. I think it's really important for our residents and our fellows, and even some of our colleagues in our clinics, whether it's academia or community, who maybe are not regularly doing TURBTs, but TURBT has to be done with a great deal of care and assiduousness to make sure it's done extremely well for a complete resection. There are different techniques these days for whole tumor resection versus traditional loop resection, but at the end of the day, it's doing it with diligence. And it's not a minor procedure, and a lot of data has supported that. But I brought to your attention that this is from 2016. I'm pretty confident that the AUA SUO will be coming out very shortly in the next couple of weeks with updated NMIBC guidelines. And so I think a lot of the material that we're presenting to you today will actually be incorporated into these new guidelines. So important BCG treatment definitions. And so this is the principles of intravesical instillation therapy. And one sees the list on the left over here, or the terminology, which has evolved over time from high-risk NMIBC, your classic, TAG3, T1, CIS, without prior exposure for intravesical BCG or at least over 2 years ago. This is oftentimes an inclusion criteria in our clinical trials. The unresponsive definition, and there were a lot of workshops that led to a consolidation or a consensus of what unresponsive meant. There's the intolerant, but what's really interesting to me is this group in the middle here, the BCG exposed. This is an enormously large population of patients that they never got the adequate course, but they, for whatever reason, maybe it was a clinic, maybe it was a lack of BCG, maybe it was intolerability, maybe they just got lost to follow-up. But this is a very interesting area of the BCG exposed, which is also being trialed right now, and FDA and EMA and others are recognizing that this is a large population, a subgroup, which is a large subgroup that needs to be evaluated. So some of the principles, at least for US audiences where there's been a shortage, is induction and maintenance should be prioritized to the high-risk population, especially as it relates to the maintenance period. The intermediate risk group, depending upon their level of additional risk factors, can be risk adapted to prioritize to what your supply has, in addition to potentially offering intravesical chemotherapies. And then, of course, clinical trials, which is a standard of care and very important. We'll talk more about that. And then there are, as you see listed here, I guess it's the 5th bullet, alternative options of different chemotherapeutic regimens around the world. And we'll talk more about that as we get into some of the more recent level 1 evidence. And then there's the notion, if you have limited BCG supply, how you can decrease to 1/3 or 1/2 dose. And there's some challenges to doing that because of throughput in your clinics and some coding issues, and that's probably differs country to country. Even in the United States, it differs by regions and by states and how you code for that. So NMIBC, 75% of the newly diagnosed bladder cancers, significant clinical challenges. Despite the effectiveness of BCG, after a well-performed TURBT, nearly 40% of the patients could end up requiring additional treatment due to recurrence and or progression. And RC has been the standard of care internationally in all the guidelines, but you could look at presentations that have been done, really nice work by John Gore and Angie Schmidt and the Cystos registry and PCORI, really demonstrating that, believe it or not, some of these patients actually from some of their quality of life measures are very happy, but other data would certainly support the notion that probably close to 90 to 95% of patients, if given their druthers, would like alternative therapies. Certainly something that would be effective and safe, and so that still remains a critical unmet need, and we do have some BCG unresponsive therapeutics that we're going to go into today. So here, the NCCN is very facile and moving forward like 2 to 3 times a year. It's one of the strengths of the NCCN, although they offer a lot of optionality, but they meet pretty regularly. And as you can see, here you have the risk groups, the BCG naive, high risk, the BCG unresponsive, CIS plus minus TAG3, T1, the BCG unresponsive that don't have CIS, and then that other group that I talked to you about, the BCG exposed, which, believe it or not, in terms of market analyses, is a huge patient population. And so here are the preferred recommendations. Here are some other recommendations, and we're going to go into each one of these particularly, as you see, and I think it's really fun to look at this now and exciting and educational. The gemcitabine intravesical system, the multi-agent chemotherapy, the nadofaragene faradenovec, and the nogapendican plus BCG. And we'll go into these in a lot more detail. So let's go to this ARS question and answer this on your device, and we'll talk about this a bit. Assume you are developing a protocol to guide clinical staff on the therapeutic options for NMIBC in your clinic, wherever you're in practice. How would you now categorize modern intravesical strategies based on current guidelines? Current guidelines do not provide specific recommendations for modern intravesical strategies. Modern intravesical strategies are recommended only in the BCG naive setting. Modern intravesical strategies are recommended in BCG unresponsive NMIBC, or I'm not sure.
Oh, there's the music.
So here's a question, Bogdana. What resources are available to providers in rural communities who lack support and/or have limited access to newer therapies?
Yeah, and this is a question for a lot of patients and certainly for a lot of providers. So I practice in Utah. We're the only NCCN cancer center for a 5-state area. So certainly I'm a resource to patients in Idaho, Montana, Wyoming, and Northern Nevada, even though I practice in Salt Lake City. So referrals and regionalized care, absolutely, especially for clinical trials, some of the newer agents. That's a very reasonable approach. But as a lot of these drugs come to market, certainly know that they're all looking to partner with you, and the ones that are maybe easier to administer in your clinic settings will be the ones that might make more sense for your practice. And we'll talk about how to tailor some of these newer agents to the patients you're seeing in the setting that you practice in.
Okay, so here's how you all responded to this, including our virtual listeners. And modern intravesical strategies are recommended in BCG unresponsive NMIBC. That got I think all of these are really very, I like the fact that there's only 8% said I'm not sure. A fifth or not, don't provide recommendations, but we'll talk more about all this. So let's keep going forward for purposes of time. I think this is a fantastic table because this, you know, as they say, bladder cancer now in the last 8 years, in the last few years of AUA and EAU, bladder cancer presentations are equivalent to the prostate cancer presentations, which I think is great for the field. And what you see here is the top are systemic therapies. We're just going to talk about intravesical, and we're going to get into that in a matter of a couple of minutes here. The top 3 you see that are FDA approved. You see their MOA, important to understand that. Dr. Schmidt is going to show you the data that led to their approval, and then we're going to show you some of the ongoing trials of looking at these 3 very exciting therapeutics that are in trial development, and they all, interestingly, have markedly different MOAs. So another question for you, assume you're developing a protocol. Well, no, did we do this one? Yes, we did this one. Let's keep going. Or I went backwards. There we go. Okay. So ongoing phase 3 trials in NMIBC, breaking it down from intermediate risk. We're going to get into this in a second. These are 2 very important ongoing studies. Envision actually completed. ABLE 32 is in progress. There are other ones as well. And in the BCG naive, we actually presented this here. But again, we're going to stick to intravesical. And then we have BCG unresponsive trials that are ongoing. These are super exciting. These have for the most part, either completely accrued or near accrual. And you'll see readouts on these in the next, foreseeable 1 to 2 years. So NMIBC, I think this is the bullets at the bottom. It's increasingly complex. Subspecialization is required. Because it's so hard to do so many things, so hard to be a generalist anymore. So that's one of the take-home messages. So I'm just going to give you a little bit of we're going to give a couple of cases. I'm about to hand it over to Dr. Schmidt, but we're going to do these 2 cases at the end and present them to you and just kind of give you a little bit of a heads up. Here's a 62-year-old woman, works as a cashier. She lives 40 miles from your clinic. She relies on her adult children for transportation. This is not an uncommon scenario for me in my practice in Myrtle Beach, South Carolina. She's BCG unresponsive. She's got high-risk NMIBC. but she's got a pretty reasonable performance status, at least looking at her picture. What are we going to do for her? And then we have George. He's 73. He's a retired mechanic. Who knows? Maybe he had some petrochemical exposure. He enjoys traveling. He's got intermediate risk NMIBC. What are we going to do for him? Okay. So thanks and all yours, Bogdana.
All right. Well, thank you, Dr. Shore, for that whirlwind. Unfortunately, the whirlwind continues, but it's a good thing. The fact that we have so many slides and so many things to talk about means we finally have more things to offer our patients. If you think about the landscape of non-muscle invasive bladder cancer, we've been using BCG since the 70s, but it was actually only FDA approved in the 90s, and it took a very long time for the next host of approvals to come in. Valrubicin is something that is still utilized in Canada. I don't use it in my practice. It's not highly used in the United States, but nadofaragene was the first intravesical therapy approved for NMIBC in the modern era in 2022, followed by nogapendican 2 years later, and most recently GEM-IDRS. And we'll talk about all of those treatments. So when we think about this NMIBC space and using BCG in these patients, they're used to an intravesical approach. That is something we're generally comfortable doing in our clinic. And so these intravesical options seem attractive both to us and to patients from a familiarity standpoint. Now, the FDA approvals for these drugs in 22 and 24 were for CIS plus or minus papillary disease. As Dr. Shore alluded to, there are guidelines talking about their use in the papillary settings, but all of these were used and approved in the CIS plus or minus papillary state because the standard of care for that patient population is cystectomy, or has been for so long, because that risk of progression is so concerning. And so if your comparator arm is cystectomy and you're the first one to market, you're going to be really careful in designing your trial. So nadofaragene firadenovec, this is the first non-replicating adenoviral vector-based gene therapy, and it delivers interferon alpha to bladder cells directly, basically increasing natural killer cells and increasing an adaptive immune response, so you have those direct and indirect immunomodulatory effects. This was a small trial, 50, in that trial, they showed about a 53% of patients with CIS plus or minus papillary had a complete response within 3 months. And of those patients who responded, the duration of response was pretty good, near 50%. And you can see that in the tail curve. Nadofaragene has data to 5 years out because it was the first one to market in 2022. So we have this data, we have 5-year follow-up, and that statistic effectively holds. One of the interesting things, and certainly different things about this treatment compared to the others, is the delivery schedule. Unlike BCG, which we deliver intravesically once a week for 6 weeks, nadofaragene is delivered once every 3 months, so on a quarterly schedule, 4 installations a year. And when you look at this data, one of the statistics that we really cared about, again, like I said, the gold standard in this patient population was cystectomy, is how many patients got to avoid cystectomy. So what is the cystectomy-free survival rate? And you see that at 12 months, that cystectomy-free survival rate is 73, going down to 43 after several years. Now, you have to remember, initially, especially as these drugs are coming in, our threshold to do a cystectomy was pretty different than maybe what it is today with the experience that we have and the data that we've learned from these drugs. We're now talking about, and I saw a question here that we'll address later about how many of these therapies do you go through. Now people are thinking about and getting more comfortable with the idea of going through more therapies. But when this trial was designed, if a patient didn't have a response at 3 months, they were taken off the trial. And the recommendation was, you get a cystectomy now. This was what the trial was designed. No one felt comfortable trying to do something else. And so nobody re-induced the way that we do with BCG and the way that a lot of the other trials that we're going to discuss built into their protocol, that if a patient didn't have an initial response right away, you were given the option as an investigator to re-induce this. So this is data that we actually looked at, very, very small numbers. We couple of us got together who had been doing this in clinical practice across multiple institutions, and between 8 institutions, we found 13 patients who had gotten reinduction just at the provider's discretion. We looked at that data, and we saw that actually up to 30+% of patients responded to that reinduction dose, meaning if you gave an additional dose, if they didn't respond right away, you could get some of those patients to CR. So some of that data initially I presented for nadofaragene may be bumped down a few percentage points just based on the fact that it didn't have that option of reinduction at the time. And notably, the cystectomy-free survival, 94%, no patients developed metastatic disease. Now, nogapendican came to market 2 years after that, and this one is a different mechanism. This is an IL-15 superagonist that is co-administered with BCG and effectively ramps up that natural killer cell and macrophage process to intensify the response without significantly intensifying the side effect profile. And this one is delivered like BCG, intravesical once a week for 6 weeks. This is the QUILT trial, or the QUILT 3 of the series of the QUILT trials. And you'll see here their complete response rate was 71% with a good tail of the curve. And so they had patients that had a good response, they had a good duration of response. Now, they looked initially, again, FDA approval is based on that CIS plus or minus papillary cohort, and that's at 71%, but they also evaluated their papillary-only cohort, and you saw their cystectomy-free rate was even higher in that cohort, speaking probably more to the disease than the drug effectiveness. Most recent in the market is GEM-IDRS. This is different. This is not an immunotherapy. This is a chemotherapy. This is gemcitabine, a lower dose, 225 milligrams of gemcitabine, that is slowly released through this device in the bladder. It's inserted through a catheter once every 3 weeks for 6 months, and then the maintenance phase is every 3 months out to 96 months. And people call it the pretzel, obviously, because it folds kind of into that pretzel once it is inserted in the bladder. That approval data is based off of this cohort 2, which included BCG unresponsive high-risk patients, and 85 patients completed that enrollment, and this is the data that you've seen presented, 82.4% complete response in this setting. Now, again, this is chemotherapy. There is no reinduction. This is all continuous, right? If patients, the immunologic concept of reinduction doesn't necessarily make sense chemotherapeutically to me. It certainly didn't make sense to the developers, and so this is as is. There is no potential for reinduction with this type of therapeutic. And you see duration of response at about 53%. And their cohort 4, which is that papillary disease that we talked about, also showed nice numbers, slightly better than the CIS plus or minus PAP, again, speaking more to the disease probably than the drug. Now, that is our BCG unresponsive space, and we've spent the most time about that because that was the dire need that we all talked about, especially with BCG shortages, BCG unresponsiveness, standardist cystectomy. That's the space that everyone entered in first, hence that influx of new therapeutics, new drugs. Low-grade intermediate risk disease is much more common. Like we said, only 0.25% of patients are in this high-risk space, so this is probably a wider swath of these bladder cancer patients. And ENVISION was a trial looking at UGN-102, a very cool mechanism. It's a reverse thermal gel, so it goes in as a liquid and then becomes gel in the bladder. It is delivered through a catheter, similar to the way we do BCG, except it's 4 separate syringes, and you do this once a week for 6 weeks. Their trial, the ENVISION trial, was looking at it as an ablation agent, so not to be done after TURBT to reduce the disease, but actually even with tumor inside to basically ablate the tumor instead of putting the patient through surgery, and this may come up in further discussions. It is being used adjuvantly as well, but the trial was evaluating its use predominantly as a chemoablative agent and showed pretty remarkable response, up to 80%, with a good durability up to 70% for those who respond. Another drug that's entering the space, this one is currently in studies, not approved. Dr. Shore showed that this one is still under investigation, is ABLE-32. That is looking at the intermediate risk space, nadofaragene once every 3 months, just like what I discussed in the BCG unresponsive space, randomized against observation and looking at a recurrence-free survival standpoint. ABLE-22 is different. This one is a randomized trial that is looking at different combinations. How do we maybe enhance the effect of nadofaragene that we saw in the original trial that led to the approval? Can we couple it maybe with gemcitabine docetaxel, something that is delivered on a different schedule, or do we couple it with pembrolizumab every 6 weeks IV, and again, randomized against nadofaragene alone, looking at that BCG unresponsive CIS plus or minus papillary. So this is going to probably replicate one of the arms, the results that you saw in the trial that led to its approval, with the possibility of reinduction in this sequence, versus an addition of this drug to other drugs that are being utilized in clinic without an FDA approval, like gemdosi, or pembrolizumab intravenously. Everybody with me so far? All right. Other trials that are ongoing in this space is that Sunrise system. So that is the pretzel I discussed that's approved in the BCG unresponsive space. And Sunrise 3 is actually looking at the BCG naive space. So this is patients who have not seen BCG yet and randomizing them to receive gem IDRS, so intravesical gemcitabine every 3 weeks, with a maintenance phase every 3 months with citralumab. Their second arm is BCG with induction and maintenance, and then gem IDRS is that group 3. This trial is done accruing, probably will read out in the next 1 year, maybe 1 to 2 years, something in that space. Sunrise 5. Dr. Shore alluded that this is a big population. This is a papillary-only high-risk group. They're also looking at the BCG exposed population here. So patients who maybe didn't meet the strict definition of BCG unresponsive, but did receive some BCG, and looking at using gem IDRS, the intravesical releasing gemcitabine pretzel, with their comparator arm being single agent intravesical gemcitabine or single agent intravesical mitomycin. And again, this trial is already done accruing as well and should read out in the next 1 to 2 years. So what about intravesical gemcitabine docetaxel? You obviously noticed it wasn't on the FDA approval timeline that I presented earlier. These are drugs that have been around for a long time, but they don't have FDA approval in the space, but they have been utilized in our clinics. Single agent gemcitabine is something we frequently use perioperatively post-TURBT, and that combination has gained prominence, especially with BCG shortages around 2019, is that right? That first paper came out about 7 years ago now, so we certainly have some experience using it. Now this is intravesical gemcitabine instilled into the bladder up to an hour, drained out of the bladder, and then docetaxel instilled into the bladder for the following hour. This is generally well tolerated, has a acceptable safety profile, and has been shown in very small prospective series and some larger retrospective series to have acceptable response rates similar to some of the newer agents in this space. But what we're looking at now and what we're looking forward to reading out is the BRIDGE trial, which is looking at using this combination up front against BCG to say, is BCG still the gold standard in this patient population? And that trial has also been done accruing and will read out probably in the next year. Now, this trial was designed as a non-inferiority trial, so it's not going to tell us which one of these two is better. It's just hopefully going to tell us, is gemdosi non-inferior to BCG or not? And then one other mechanism I want to discuss, this drug is not FDA approved yet, but I will mention it in some of the trials we're looking forward to seeing, is cretostimogene grenadenorepvec, and that's an oncolytic vaccine engineered to express GM-CSF in mutated or deficient RB cells. So this has an immune harnessing mechanism as well, which enhances T cells, inducing tumor cell destruction intravesically. They did an initial very small trial combining this with IV pembrolizumab, showed a 54% CR rate, and they've done a larger trial, Bond 3, which has been presented at the AUA, I think last year, is not FDA approved yet, but did demonstrate a 75% complete response with a good durability, up to 50% by KM estimates. And they also have a separate cohort for papillary-only disease. That data also, similar to the other drugs I've discussed in this space, looks a little better than the CIS plus or minus data. And the last one I want to highlight here is the LEGEND trial, which is detalimogene voraplasmid, and this is a slightly different mechanism. This is not a live virus, and the administration of this one is 4 treatment cycles. So as opposed to once a week for 6 weeks, it's weeks 1 and 2, and you skip a couple weeks and then you do 2 more. And this is administered via catheter in the clinic as well, held up in the bladder up to an hour. And this trial, we had a small presentation on late-breaking abstract on this data at the AUA, but this is still going to read out more. We need more data and more time to follow up the durability of this treatment. Now, I want to pause for a second and see if there are any questions we want to address before we move on to talking about these as a whole and what we're looking for in this population.
So one question that came up, Bogdana, was if you have accessibility to the FDA-approved BCG unresponsive therapies, have you had experience in sequencing them?
Yeah, a small amount of experience, right? Some of these have only gone online relatively recently. So Gemdosi is one that I've been using in BCG unresponsive for several years. Nadofaragene is the first one that came to market, and so I've had patients on that. I have some patients who've been in response since they started it. I've had some patients whose disease recurred, and I have moved on to other therapies for them. I don't have nogapendican in my practice just because of the BCG shortage. You have to couple it with BCG. I don't have enough BCG for my own patients for induction, so I don't use it in this space. And GemIDRS is relatively new, so I haven't had anybody need second line after it yet, but I only started using it in the last 2 months. But I think we're all sequencing them based on patient factors, safety factors, symptom factors, not necessarily true guidelines or comparative effectiveness, because that data doesn't exist, right? It's very hard to compare across trials. These populations are different. The way the trials were designed was a little bit different. And so we really don't know scientifically or from an efficacy standpoint which one of these should be given first and which one works better second. I'd love to get biomarker data to help us figure that out. But I think right now we're really relying on what we can get, what we can safely get the patient to tolerate, and what the patient's goals are. How many lines of therapy are they willing to accept in order to salvage their bladder?
Another question that came up for you is additional training needed for the GemIDRS insertion and replacement? Who does it? Is it similar to a traditional catheter?
Yeah, so every practice is going to be different. In our center, I do some of them, and I've trained my PAs to do them as well, just because logistically, volume-wise, I can't do them all. It is very much trainable. The catheter that you insert is a little bit stiffer than a traditional catheter. If anybody does cryotherapy in the room, it's more like a cryo catheter. It's just a little bit stiffer, but it is very easy for anybody who knows how to catheterize a patient, knows how to use a cystoscope, to learn how to do it. And then to remove it, you just use a cysto and a stent grasper. So our PAs don't do our bladder cancer surveillance, but they do stent pulls in the clinic. And so this easily flowed into their practice, and there's training modules available provided by the company, and most of us urologists can train our practice providers to help address some of these. All right, so maybe we can go into talking about this a little bit. So everybody who's taken care of bladder cancer patients and administered intravesical therapies is familiar with how challenging it can be, especially as patients have had their disease for a long time. Their bladders can really bear the brunt of it. And the toxicities are really common. You see dysuria, you see urgency, frequency, urinary tract infections, spasms, hematuria. Most of these are relatively mild and can be quickly resolved, but some of them can be a challenge. So here's a question for everybody. Now that we've bombarded you with all of this data, how would you plan to educate your patients to manage the adverse events associated with intravesical therapies, such as bladder spasms and micturition urgency? And again, I didn't really spend too much time telling you how I manage these in my practice, so maybe I'll do this for a second as you guys are filling this out. But hydration for some of these is more important than for others. So for GEM-IDRS, you really do want your patients to hydrate a lot to tolerate that well, because the emptier, the drier that bladder is, the more symptoms they have with a device sitting in it. And so counterintuitively, a lot of these patients are actually used to trying to dehydrate themselves. They try to drink less so they pee less. But for GEM-IDRS, that actually makes things harder. For the other ones, that is less of a concern. Limiting caffeine day of the procedure. Caffeine's a known bladder irritant for all of these patients. I mean, it's hard for anybody to tell me to stop drinking my cup of coffee, but you sometimes have to tell patients that that will help you, and some will try to cut down on their caffeine. And again, counseling that most of these are local, low grade, and easily managed with all the tips and tricks that you already have in your arsenal, your phenazopyridine, your anticholinergics, beta-3 agonists. All of those are your tools and friends to help manage these in this patient population. And sometimes actually using them before they get these treatments is what we've been doing. So if you know a patient has a troublesome bladder, then maybe loading those before can be helpful.
Okay, so this is, I think, a great slide in terms of the content. So what's real-world practicality for everybody using different approaches for intravesical therapies. And so here we look at nadofaragene firadenovec. It's every 3 months. It gets shipped to you. It's stored frozen. You thaw it. It's completed in a water bath thawing. It basically takes about 25 minutes. One of the caveats on all three of these therapies, they're all, have a cost associated with them. So let's, for purposes of the discussion, you've got that figured out and it's accessible. Once it's thawed, it can be stored for up to 24 hours at room temperature and for 7 days in a refrigerator if for some reason the patient can't make it to the clinic that day. Something happens, something unplanned. And it's a 1-hour installation. It's 75 ml. It's basically your kind of classic catheterization. There can be some frequency and urgency, so strategies for essentially antispasmodics and anticholinergics, as Dr. Bogdanovich Dr. Schmidt just said. So, and nogapenegan is weekly as opposed to every 3 months, and it's given in conjunction with BCG. So you have to have the BCG accessible to you. It is also shipped and stored and refrigerated. There's the mixture components that you see here. It's a 2-hour installation on its product information. And the GEM-IDRS is every 3 weeks for the first 6 months, and then every, I believe it's every, is it monthly for the next 6 months? I forget, but
it's every 3.
Every 3 months, that's right. So it's every 3 weeks the first 6 months, then every 3 months. So,
and I will interrupt you for just a second since you're on GEM-IDRS. Someone asked a good question. They asked, is the device ever inadvertently voided or dislodged, and what do you do when that happens? I haven't had that happen myself, but I have heard of it happening. I've actually heard of it happening in female patients more than male patients, for what it's worth. But you call your doctor, you let them know, you bring it in, we throw it away, and you get a new one.
Yeah. Pretty, and you look at this, the configuration of it, it's basically the size of 2 overlapping, quarters or coins, so it's pretty hard to have that happen, but anything is possible. And I think, as you mentioned, the insertion and removal is pretty standard for the most part. But these are important considerations to how you would work and go through the throughput and the implementation in your clinic. And everybody has to think about this and approach these different pros and cons of the schedule of events, the storage, and who's going to be delivering the therapy. So rethink your choice. Assuming the treatment options for NMIBC are approved in your country and that cost is not a problem, which factors, and it's approved, which factors do you value regarding administration practicality? Select all that apply. Frequency of administration, preparation time in the clinic, storage considerations, off the shelf, as we say, versus freezer and refrigerators, and impact on clinic staff bandwidth. Obviously, no wrong answers to this. They're all good answers. So, all right, let's see what we have here. Yeah, I mean, it's all of these are real considerations. And I think that's sort of the, embarrassment of riches that we're all going to start to have, hopefully, as we get more expansive in our approvals. And it takes time to go through and explain to patients the efficacy, the mechanism of action, and of course the safety profiles. All right, let's go to the next slide, just for purposes of. Okay, so here we have this case. Dr. Schmidt, let's see what you think and see what the audience thinks. So here's Ruth, the 62-year-old. She has a CIS plus high-grade TA. She's BCG unresponsive. She's had adequate, appropriate induction maintenance, essentially defining her unresponsiveness. She has a little bit of fatigue and fever on the BCG. We see that sort of mild flu-like symptoms. She has some COPD and mild renal insufficiency. She's restaged. She has no residual tumor after her last TURBT. Let's assume she's got obviously the CIS and the high-grade, the TAG3. What are some important points to consider? Our past history. Well, yeah, she had the BCG induction maintenance, comorbidities, BCG shortage. She's 40 miles from the clinic, considerations for staff and care team. So let's go to the answers, see what you think. What would you do now for Ruth? She can get reinduction with BCG. She's already had induction maintenance, of course. Nogapentin is basically given induction 6 weeks, and the classic SWOG maintenance protocol with BCG. Anatoferagine ferridenovec, which is given intravesically every 3 months. Gemdosi, which has some issues regarding its administration in terms of time in the clinic. Some places have hood requirements. And then the economics always plays into these considerations as well. The IDRS, gemcitabine, Q3 week to 6 months, you're not sure. Okay, well, it looks like the overall majority are picking anatoferagine ferridenovec. It's interesting you showed that presentation of the data. We actually did the phase 2 with the SUO-CTC. It was really one of the great examples of community-based research sites and the SUO Clinical Trials Consortium and the original phase 2 paper, and we ended up publishing that in JCO, which then led to the Lancet Oncology paper. So it was a really good example of a lot of different trial sites working together to get that across the finish line, and Colin Dinney really led that really very nicely. Okay, next, we'll go to the next slide here, and here we have George. He has low-grade recurrent NMIBC. He's on aspirin, and he's on blood thinners. Boy, it seems like some days everybody's on a blood thinner. He's restaged, no residual tumor after TURBT. Important points to consider for purposes of time. You see all those. Let's go to the question. All right, because I guess we're short on time. Scan the QR code to answer the final follow-up poll and to ask for any questions. We're happy to respond to those.
And I will I can start answering one of the questions that
Yep.
someone put in the chat. So for patients whom you'd advise an intravesical installation approach, is it because they refused radical cystectomy or are not fit for radical cystectomy? So that's a really good point to make, that in all of these clinical trials that enrolled in this patient population, that CIS plus or minus PAP, they all had to be ineligible or refusing. And if you look overwhelmingly across the trials, 80% unwilling, maybe 20% not fit. So for the most part, these are patients who want to keep their bladders. And I think, when we have the cysto data now, like Dr. Shore discussed, that a lot of these patients' quality of life actually might improve after a radical cystectomy, but they don't know that. They don't believe that. They want to fight for their bladders. And there's a lot of people, even in the urology community, who still maintain that the best bladder is the one that you're born with, right? And I believe that for a lot of our patients, this is a really big deal. They don't want to lose their bladders. They're willing to fight for their bladders. And I think majority of patients who end up going down this road of multiple sequenced treatments, it's because they don't want to lose their bladder, not because they're truly unfit for it.
Another really great question here I'm going to ask you, Bogdana, but while everybody's looking at this, I love this slide because it really speaks to the importance of clinical trial participation. So hopefully many of you are doing clinical trials, and if you're not, you're on some sort of hub and spoke model where there are sites near you that are doing these trials, because this is how we advance our bladder cancer care. But here's a good question. I think it's reasonable. Bogdana, is viral shedding a concern with gene therapy?
Yeah, these are not live viral particles, and so I'm not concerned about it. And in fact, even with BCG, right, which is live, we tell patients to bleach their toilets after this when they're voiding. But with none of these newer agents, do you have to give patients those requirements?
It's a great question, but it's an important question, especially not so maybe it's kind of intuitive to physicians, but for our staff and who aren't as up to date on the literature as you would be. It's important to reassure them. Diversity is always a really important aspect. We want to make sure that we have a representative population. So that's always really crucial in doing clinical trial work. So that's another key aspect here. So I think with that, we're really kind of good on time, unless anybody has a really important question. We take it from the audience. We have microphones out there. If we haven't answered them for you, you can get all the slides. You can download this here. We'd love to get your feedback on the content. And then also, there's an opportunity. Question?
Hello?
Yes, sir.
Yeah, I was just wondering, is there any concern about progression in the year that it's taking to give this medicine? 3 months, 3 months, and 3 months.
Right, so we were talking about nadofaragene firadenovec. So the progression in these patient populations was very low. And I have the data slide here. Obviously, that is always something that we talk about, the risks of ongoing therapeutics in this space and whether we want to take that risk with that patient. But overall, I think the progression rate is very low, and the metastatic rate in that 1 year is very low. I can tell you that even in our small reinduction cohort, there was one patient who progressed to muscle-invasive disease, and that was after most of those patients having been reinduced, they had had several doses. And then if you look at in the nadofaragene 5-year data, only 5 patients experienced clinical progression to muscle-invasive disease.
Yeah.
Occurrence in a 1 year period.
Yeah, the bladder intact event-free survival in the longitudinal studies is incredible. It's like 1 or 2 cases max. So if you're monitoring these patients closely, the bladder intact event-free survival is essentially 0. Of course, there always can be exceptions. I think that's a very important question that you asked, and it should be, and that's one of the things the FDA and the agencies always want to make sure in the trials that we're looking at, particularly in the BCG unresponsive and even in the BCG naive populations. So it's a great question. So thank you all very, very much. If you continue to fill out, I think there's an opportunity to figure out if you won any more of the, raise your hand if any of you won any of the gift certificates. I don't know. Everybody raise your hand. If everybody raises your hand, you have to get one. Any closing comments, Bogdana?
No, I think this is great. I know this is a lot of information. It's a new and developing space. This data is going to continue to evolve. Our comfort with managing these therapeutics is going to continue to evolve. So continue to stay engaged, continue to look at the posters, abstracts, presentations, and certainly feel free to stay after, ask us any questions if you have anyone.
Yeah, thanks very much. Download the material, review it. This is a great time for our patients. A lot of new advances already approved and more to come. Thanks very much for attending.